Um, I'm really pleased to have our friend and colleague, Dr. Roop Gursahani, lead us through a session on advanced care planning. Dr. Roop he's currently a consultant neurologist and epileptologist with the PD Hinduja National Hospital. And he has had a very illustrious career in terms of where he's worked and his experience in the field of neurology. He's held several senior positions in institutions, hospitals, and organizations. And he's been the founder trustee of FINE, which is the acronym for the for Indian Neurology Education. And he organizes teaching courses in neurology. I know he's also started teaching neuropalliative care, which he's pioneering in India. And I hope we will see a lot more of that happening in India under his guidance. And he is also on the steering committee of ELICIT, the interdisciplinary task force of intensivists, palliative care physicians, and neurologists for end-of-life care in India. And they have done some remarkable work in the field in appropriate end-of-life care in our country. And they've been working diligently to bring in better procedures and laws regarding appropriate end-of-life care in the country. So I'm going to hand over now to Roop to take us through this session on advanced care planning.
Thank you, Smriti. Thank you, Pallium, for having me on again. So I'm going to share my screen and start off with that. Just let me know if everything is audible, visible. Yep. Okay.
Yeah, yes, your screen is visible. We can't see you though. Your video is off.
No, my laptop camera has failed. Until I buy a new laptop, it's not going to. So I'll once the slides are done, then I'll switch over to my phone and then you can see me.
All right, thanks.
Right. So this session is about Living Will's advanced medical directives, advanced care planning. And although, I mean, you are obviously learning this as participants in a course, but these are also lessons for all of us, because these are things that we all need to know, understand, and perhaps even do. So this actually, some part of this comes out of a lecture that I had prepared for the International Neuropalliative Care Certificate course. And if any of you is aware of EPEC, Education in Palliative and End-of-Life Care, some slides are partly from there, since I'd worked on the slides there as well. Okay, so we'll try and define advanced care planning, including definitions and assigning proxies. We will try and appreciate the principles and history underlying advanced care planning and the variability across cultures and jurisdictions, a little more right towards the end. Try and apply a semi-structured format for facilitating them. Let's start by defining terms. And there are three terms that come up repeatedly when we talk about end-of-life communication. The first is goals of care. The second is advanced care planning. And the third, which is really at the absolute towards when decisions have to be made, is shared decision making. Now, goals of care are basically part of a continuous conversation with the patient and family over a period of time. And this is different from just talking about treatments. You're actually asking patients to realistically figure out what lies ahead in terms of prognosis and so on. And it's basically an individual clinician's responsibility. So is something feasible, is something practical, that way. Advanced care planning is planning for future care. So to decide whether to receive or not to receive different types of interventions when the patient can no longer comprehend or communicate. So these are documented outcomes, means documents that come out. It has to be part of public policy and it needs a system, including legal support to make it happen. If all of this is done right, then when crucial decisions need to be made, they can be made between the clinicians and the patient, or more obviously the proxy or the surrogate decision maker, and they can be made in the moment because both sides know where they are, and there is a fair amount of thinking that has already been done if this goes well. So this brings me to the definition of advanced care planning, and because it was a somewhat vague term, there's a European and a American group that sat down and did it by a Delphi process, and these are the consensus that we have. So advanced care planning is a process which supports adults at any age or stage of health, so even healthy adults, and we'll explain that a little further, in understanding and sharing their personal values, life goals, and preferences. Probably the most crucial part of this is choosing and preparing another trusted person to make decisions when one can no longer make your own decisions. And for that person, the important thing is explain to them that you will now become the patient's voice, because it implies advocacy and understanding, and it implies channeling their loved ones' feelings rather than making decisions for them. And the goal is to ensure that people receive medical care that is consistent with their values, goals, and preferences when the time comes during serious and chronic illnesses. And you have, again, in this terminology, you have these terms, 6 of them. Advanced care planning is the process. Healthcare power of attorney is the legal document that appoints an agent to make future medical decisions, which becomes effective only when the patient becomes incapacitated. And there are various terms that I use: durable power of attorney, healthcare agent, proxy, surrogate decision maker, all of those. Surrogate decision maker typically is when somebody is appointed, in a sense where this has not been done in advance. But if you see, there's no difference in the role here. Ideally, this is done by a hierarchical system, so spouse, adult children, siblings, and so on. And in India, we don't have, ideally it should be done by legislation. But in India, the only one that we have is in the AIMS end of life care guidelines. So if any of you looks it up, you'll see that there is a hierarchy that is put down there. Right. Then advanced medical directive are the legal documents that describe these preferences and appoint a surrogate together. A living will, which was actually the first document that was designed for all of this, actually just documents an individual's wishes regarding initiating, withholding, withdrawing certain life-sustaining medical interventions, and again becomes operative only when the patient is incapacitated. So you can see that the advanced medical directive combines both the healthcare power of attorney and the living will into one. And the process that you go through to come with this document is advanced care planning. Now, towards the end, you actually have to have clear-cut orders that say, do not attempt resuscitation, give comfort care, give full therapy. Those are orders for life-sustaining treatment, which are basically signed out by a doctor and somebody from the patient side. And these are portable between healthcare settings. Again, various states in the US have specific forms for this, and I'll again show that to you. Why do we need a healthcare power of attorney? This is because the living will can cover only a limited range of decisions or options, and things change over time. So ideally, you have somebody who can discuss with the patient and the doctor, who usually has a copy of the documents and has already confirmed readiness to serve as decision maker. Some people who make these documents may give their healthcare power of attorney limited discretion, so that they can only make sure that the patient's wishes are followed and have nothing else no other decisions. And as I said, surrogate decision maker, although we do it by convention, ideally it should be done by specified by legislation. Now, the living will was first devised in 1967, and it soon became a legal document. It tends to be jurisdiction specific, so you have to be aware of what is available in our area. As of now, in India, we do not have anything. We just have broad permission to make these. Sorry, I'll just. And because they are very general, they tend to have very limited impact on the actual decision making. But they address CPR, life support, hospitalization, and so on. As I've said earlier, the combined directive combines both. Can also include a value statement. We'll speak about that a little later. And it has space for incorporating personal preferences. Across the world, in developed countries, commercial and not-for-profit options are available. So you have something called the 5 wishes document, which you have, if you do it for a single document, they allow you to download for free. But if you want to use it and sign it out and all that, then there's a charge for it. Obviously, if it comes from a government source, then it is likely to be free eventually. Now, this is I'm showing you snapshots of the document that is available on the Pallium India website, which our group worked on. There is the same document is available on the Indian Association of Palliative Care website as well. You can see the points that are highlighted. So if somebody can no longer take part in the decision-making about their medical treatment and have reached a stage of terminal illness or have no reasonable expectation of recovering or are in a persistent vegetative state, then because of the Indian requirement of having a panel of 3 doctors, you require these 3 doctors to confirm whether any or all of the 3 situations above are confirmed. And then if so, then I should have the following life-sustaining treatments removed. And these are listed. They can be ticked. If somebody says that I'm okay with getting IV fluids, but not all the rest, or I'm okay with getting CPR, but not all the rest, they can obviously tick or cross off whatever it is, unless otherwise specified. All these are in the list of what must not be done. And then to secure compliance, to make medical decision makers, these are the surrogate decision makers. Now, you can cut out. So if you cut out medical decision makings, then the only thing that the surrogate can do is secure compliance. But if you leave this intact, then all of this is possible. And you have 3 names. Now, these are 3 people who are in order. It's not as though they work as a committee. No, if 1 is not there, then 2. If 2 is not there, then 3. Typically, it is understood that the 3 of them will may be available. They will probably discuss, but it is only the person, the first in the list or the second, whoever is there, who actually does the signing off. It's not that all 3 will sign off. And the thing about this document is that it can be revoked verbally anytime. So, somebody may not be fully conscious. They may be even a little partly conscious. And if they are asked about it, they say, yes, no, I do not want to go through with what I have. Then it is instantly revoked. It can only be made in writing, but it can be revoked orally. Right. So, in various states in the USA, they realized that they required something a little more. So these are physician-side medical orders with checkbox options, together with a system for recognition by all healthcare facilities and emergency service providers. And this has to be signed by the physician and the patient or the patient's proxy. And it covers 3 items: CPR, level of medical interventions, which ranges from just comfort measures, which means basically palliative care, up to full treatment, including feeding tubes and so on. They're put out on bright lime green paper, and multiple copies are made and are put everywhere. Typically, if somebody has made them, then 1 copy will be up in some prominent place in the home, usually in the kitchen on the refrigerator. so that if somebody is found unconscious, people know where to look for it. And this document you can get it on this website. And you can see the way it looks. Bright green, nobody can miss it. And you tick off, attempt CPR, do not attempt CPR. If the patient is not in cardiopulmonary arrest, then you do the other things. Do they want full treatment, which means they go to hospital, ICU, whatever, limited treatment, which means that they do not get intubation or comfort measures only, in which case they may or may not be taken to hospital, but nothing aggressive will be done. And this is the full document as you see it. Do we have something like this in India? Yes, we do. In 2020, the Indian Council of Medical Research, I was part of the group that put together DNAR forms for Indian usage. And you can see how you should go through this conversation is spelled out in the algorithm in the paper. This paper is available free, and I'd suggest that everybody needs to download these, especially these forms. These forms are usable. And these are the forms that you are supposed to use for taking DNAR consent. Obviously, people do take it in, just take it written on normal paper also. But ideally, if you use this form, then you go through the regular process. Now, when and how does somebody start doing this process of advanced care planning? This comes from an organization called Respecting Choices, and I'll speak about that a little later. And Respecting Choices is an NGO in the US, and in their area, literally 99% of people are covered. So what about young people? So if somebody is young and healthy, then about the only thing that would concern them is the possibility of permanent brain injury. And this is also the kind of person who, well, might want to sign up to donate their organs in case they have a massive accident and are brain dead. And so this essentially is for healthy adults. Now, how does that work out? So I guess you recognize both of these gentlemen. Barack Obama, during his first presidency, actually announced that he and Michelle Obama had made their living wills, specifying, he didn't give any more details, but that was it. Now, why would at that stage, he was not even 50. Why would he do that? Remember that the US president has an occupational hazard of being shot in the head, right? What about Michael Schumacher? Nobody knows if he ever did make this kind of a document. But remember that sometime after he finished his racing career, he had a skiing accident in which actually he just toppled over and cracked his skull on a rock. And this was downloaded almost about 3 or 4 years ago. So this is about 5.5 years. At least until that time, he could not stand or walk unaided. 2.5 years after the accident. I'm sure he's not terribly better because we haven't heard anything, but we don't know throughout his racing career whether he ever thought of this. And why is this so? This is a question that, well, the Yaksh asked in the Mahabharata, and Yudhishthir pointed out that countless creatures reach young aboard, yet those that remain behind believe themselves to be immortal. What can be more extraordinary than this? But it is not everywhere so. For instance, in countries where advanced care planning is a serious process, there is a fair amount of campaigning to make sure that people are aware that they must actually undergo this process. Now, what if somebody develops an illness? So somebody who has an illness, it could be minor, but it could also be major. So for instance, when cancer is first diagnosed, or when somebody starts off a program of treatment where bad things could happen. Somebody is preparing for a bypass, like that. This is where you need to seriously consider making this kind of a document. And in the United States, if you are admitted to a hospital that is supported by the central government, then you are asked at admission, like our informed consent form, you're also shown this form of advanced care planning and said, have you made it? Do you want to make it? Why is this important? Well, this was a 67-year-old lady. She's still under my care, who came in with a bad brain hemorrhage, but got operated, all tubes out, remained paralyzed on the left side. And her husband, one day, almost about 3 years after this had happened, one day he was looking very depressed, and I sat him down and asked him. And the point was, this lady herself was no longer depressed, but she was very sure that she had not wanted all of this. You can see what even her brother said. And unfortunately for the old man, he was taking care of her alone. Right. What about somebody who is a little further in life, when the end is near and survival of 1 year or less is expected? Remember that 90% of us want to die at home in our own bed, but in reality, across the world, 70 to 80% die in hospital. The stronger the advanced care planning process, the less the numbers. I've already shown you the living will that we have put up, which is right now the current will that I would recommend until we are able to put together a validated, consolidated version, which will happen in time. So for this, it is important for us to know how we die. Now, one thing that most people are not aware of, that sudden death is actually comparatively more common under the age of 50. And you can understand that young men do dangerous things, stupid things. They become terrorists, they become soldiers, they drive motorcycles too fast, or they smoke too much and get heart attacks. Once you cross the age of 50, then it is very likely that you've gotten through all these risky behaviors. And after the age of 50 years, less than 10% people die suddenly, unless you are somebody like our long-haired president who had a lot of punya. So he got exactly that kind of death at the age of 84. About 20% of all deaths are due to cancer, and these are people who are typically in their 60s. And in cancer, there is this interesting thing about cancer biology. You can survive with a certain amount of tumor burden until it crosses a point of no return. And then it is a waterfall trajectory, which means a very predictable kind of prognosis. But initially, this is somebody who's functioning fairly well. Some of you may remember Mr. Manohar Parrikar, a former defense minister and Goa CM, who died because of CA pancreas. And another person who died of CA pancreas, who actually said his mind on this. I'll leave you to read this quote. I can't, I mean, I find it still very difficult to read, because this speaks of so much strength of character. What about somebody who has various kinds of organ failure? This accounts for about 15% of deaths. These are people who start off at a reduced level of function and keep deteriorating with crisis, admissions in hospitals, until they finally pass off during a crisis. Typically, this affects people who have reached their 70s, and we call this the looping trajectory. And this was Girish Karnad, who died of respiratory failure, but he died in his 80s. Right. And for about 50% of us who cross into the 80s, we come into the 80s at a poor level of function and keep dwindling down. So it's called the dwindling trajectory. And well, those of us who are healthy or take good care of ourselves, that's going to be our fate. Old age, frailty, dementia. I suppose you remember Atal Bihari Vajpayee, after he lost his election, the election in 2004 was not heard of again. We didn't actually, until he finally passed away in 2018. These are the four classic trajectories. The fifth trajectory was identified. Basically, this means somebody who has a catastrophic event, and because of the current standards of intensive care is rescued, but does not improve significantly and remains in that state until death. This obviously can be brain injury, stroke, or traumatic brain injury, but it could also be a healthy elderly who gets a systemic illness. And this is something like, even I've seen patients who had a hip fracture and never walked again after that and actually just passed away. So very old people can also have, who are well functioning, can have a significant illness that pushes them. Otherwise, typically this is brain injury. But both of these are, in a sense, artifacts of intensive care. So the point is that for about 85 to 90% of us, death is predictable some weeks or months before it occurs. And I'd like to point out the three famous nonagenarians, people in the 19s passed on in 2018 and one in 2022. Two of them, April and November, were the Bushes. Both of them died in their own beds in Darbar with children, grandchildren, dogs, cats, everybody around them. What about poor Atal Bihari? He died on ECMO in the AIMS ICU. And Lata Mangeshkar's incomparable vocal cords were raped not once, but twice. She was intubated a second time. So my rule is, if you're an Indian VIP, you have to be tortured to death. Remember that the body can be kept alive indefinitely should we choose to do so, unless somebody takes charge. Is it possible to pass away comfortably at home? Yes, it is. Even in India, it's the norm in rural Kerala. And if you have not read this document, you should read it. The Lancet Commission on the Value of Death, bringing death back into life. 5 principles that they set out, that death and dying are social, and those social determinants must be tackled. It's a relational and spiritual process rather than just a physiological or pathological event. You need networks of care to support the people who are dying and those who are grieving. You have to make these conversations and stories about death, dying, and grief common and recognize that death has value. And they actually said something very close to our realistic utopia has been achieved in Kerala. These are the neighborhood networks that all of us should be aware of. So a little bit of history and social perspective. Remember that these actually started off as a human rights issue, and it started off in the US. And I'll explain why this happened. So it was first discussed, written up by a Chicago human rights lawyer, and then California actually passed this as a state law. And then it became literally like a political competition between states, so that 40 more states had made these legislations. Compare that to India, we are very far behind. And finally, the US courts actually followed the legislatures. In India, it has been the other way around. Our courts have done this, our legislatures are still waiting. And finally, the US Patient Self-Determination Act became applicable to the whole of the United States. This act incentivizes institutions to inform patients of their rights, to participate in their own healthcare decisions, prepare an advanced medical directive, and it also prohibits institutions from discriminating against patients who refuse to make. So, fairly complete. But the problem with these advanced directives is that wherever it has been checked out, they don't seem to have enough impact on actual end-of-life decision-making. Because people don't usually use these legal tools. These forms often do not provide enough guidance. Patients' goals may evolve. And even if a patient's AD is available, it may not influence care. Worldwide, there's a lot of variation in legal validity, especially in India, for instance, validated in 2018, but practically never used except now. Now it is going to be available for us. So if you look at it this way, you will think that this is not very useful, except that you realize that when the document approach changed to a communications approach and the focus on the document changed to advanced care planning, then that is when things started to change. And advanced care planning now has become like a open communication, which most, I would say, a lot of doctors in the US would engage in. I mean, even we often do it, except that we don't know that we are going through this process. And it prepares patients and proxies for best possible in the moment shared decision. You have to understand that just as pediatricians have to work at vaccination, anybody who is interested in taking care of patients towards the end of life has to work with advanced care planning. It is effectively our vaccination for palliative care. But to make this effective, you need a system and a cultural change. For one thing, the legal and the healthcare systems have to make this possible. Professionals have to be trained. The public has to be trained. You need to put together a system to make this happen so that you have those tools that, like, I mean, as of now, we only have that one document, we need more. And then finally, there has to be research to see how things are going. And there are two places in the world where this is now being done fairly routinely. In fact, the third is actually in Asia, where it is heavily supported by the government. It's Singapore. So ACP, Advanced Care Planning Australia, is a NGO which is funded by the Australian government. It gives free education and support for professionals. And the discussion and counseling can be done initiated either the patient or the healthcare provider. And it's been seen that depending on the area of the country, 30 to 50% of patients will have these documents when they are admitted. And you can look this up. And how does it work? Well, a randomized controlled trial confirmed improved patient and family satisfaction significantly. So when the ACP was made, 83% were very satisfied as compared to less than 50%. And just about 10% were not satisfied as compared to 26%. So you can see the difference that it makes. In 2018, I traveled to a place called La Crosse. It's a small little city in a state called Wisconsin. And it also makes the best Bloody Mary in the, that's what they claim, but it was really good. So there, in the 1980s, a local health system, which ran the local insurance and so on, hired somebody who had this idea to start this process off. And he devised, a gentleman by the name of Bud Hams, he devised a system by which facilitators, and they were not physicians, they were, I mean, they could be nurses, they were in fact lay people also, a copyrighted systematic program. And I showed you that the step process, the first steps is for all adults, the next steps are for people with progressive illness, and the last steps are people who are likely to die in the next 12 months. And they are so successful that more than 90%, in fact, the figure is close to 99%, of deaths in its area are actually covered. And how does this make a difference? Well, costs of care in the last 2 years of life, where this program is operative, less than $50,000, as compared to the rest of the US is close to $80,000. And if you remember, people dying in ICUs, typically across the US, even now it's about 18 to 20%, sometimes more. Here it is always under 10%. So it has proven its value. So quickly to look at the components of advanced care planning, you have discussions about proxy, goals, options, treatments, and how do you do it. I'm just going to quickly run through the basics of it. Remember that we need to have the basic skills to perform this. These skills are clarification of values, communication, the basic medical knowledge to put all of this together, and then knowing how to complete this paperwork. So some of this is a little bit of detail that you will get on the PDFs when Pallium sends it to you. Remember that ideally this has to be proactive. It has to be integrated into routine care, and it evolves with the patient's situation. It provides guidance. Ideally, it ends with, or at least it reaches the stage of completion of an actual document, preferably going on to what is called POLST or a DNAR order. How does it help? It reduces anxiety and improves clarity, builds trust, reduces hospitalization, and increases the utilization of palliative care services. And I've already shown you that it reduces the cost of end-of-life care and does all of this without actually increasing mortality, which is, something that is true of palliative care as a whole. So how do you put it into practice? Well, when do you start discussing it? Actually, it should be a routine process. In people who come in, especially the elderly, as part of an annual visit, whenever they come for a checkup, or when events occur, when somebody's function deteriorates, or clinical status deteriorates, when they have an illness and are hospitalized. And there's various things like withdrawal, weight loss, and so on. All those things that we know that somebody is towards the end of life. You have to initiate, educate, discuss, document, and close. And I'm giving you some amount of scripting. Now, the important thing to remember is that it can be done by any discipline. It really does not require doctors. In fact, respecting choices doesn't like doctors doing it because, well, we doctors tend to talk too much. And here you need actually to hear the other person. You have to start by assessing the patient's current knowledge and then check if they have a document and go on to that. What I say is by saying that I encourage all my patients to think about planning for the future. There is no right or wrong answer here, but it is good if I know your wishes in the future. And people appreciate that. In neurology, it's important to know whether the patient has decision-making ability, though this is not done as formally as you would do it for a legal document, but you do need to find out whether they understand what we are doing, appreciate, can reason, and can communicate. So this is something that very often we can figure out as we take the history. Somebody needs to be muted. Can you mute that, whoever is, that noise is happening? Yeah. Okay. So how do you do it? You first ask their permission. And I'm going to run through this quickly because these are script parts that you must read and perhaps use. Would you like to talk about what may happen in the future? How do we make sure that you follow your wishes? Is there someone else you wish to involve? If you became unable to tell your doctor about care, who would you want to make decisions for you? If they have, say, a serious illness, which is even like cancer, you may have to say that this is not going to be cured. You have to find out if they have had someone else having end-of-life decision. Can we mute whoever it is, please? Okay. Check out values and actually directly ask, which I almost always do. If you had a problem and ended up in the ICU, would you want to be put on the ventilator? So if you go through this, you will find out that patients and family members may have perceptions of aggressive care which comes from TV and movies. And they should be made to understand that that is not realistic. So you have to actually ask them to, you have to ask them to actively choose invasive care. So it's not, do you want it? It has to be framed in that way. And as you go through it, you will also discuss their goals of care. Now, goals of care usually come through when the patient or the family is making, when we are talking, these statements come up. The goals of care that we normally understand are longevity, maintaining function, and making comfortable. Sorry, I'll just have to take this. Balki, I'm giving a lecture. I'm giving a lecture. Right. So when you do this, you figure out what matters to the patient and family, and you can take it further from there. Again, I'll leave this. And then you go through the role of the proxy. because the family needs to know, they have to be asked who will be, I mean, obviously we've asked who is going to be the proxy, and make them understand this should ideally be in writing. What I usually do is, I will have one of these, the forms that I've shown you around with me, and I will hand it over to them and ask them to bring it back the next time. And obviously you have to review it over a period of time. Remember that this discussion is not going to happen in one visit. So in a patient who is, say, for instance, has had a diagnosis where you know that they may not have more than a year or so, then over the next 2 or 3 consultations, you finish this through. The values that are important are about, dependence, dignity, and you can actually have online decision aids that people can use to think through their own minds about this. Autonomy is not always individual. In India, very often it's relational. So very often the family will have a perspective on this. And in neurological patients, I often find that when I bring this up, the family actually is very supportive. It also depends on people's attitude to health, the religious background, living environment, finances. People who live alone will probably want to make these documents. There are lots of resources that are available on the net for anybody who wants to explore this. At the moment, these are not Indian, but we hope to have Indian resources up soon. And then finally, this needs to be documented and ideally copies sent to all relevant family. In India, we are also, according to the new Supreme Court judgment, we are also supposed to send it to the courts. But I mean, you don't have to, you can just put it in a registered post and do that. And then obviously, once you've done this, then you close the meeting by making it clear that regardless of whatever the decisions are, you are with them. And ideally, you need to keep rechecking them. The challenges are that people always wait for the right time. We fail to clarify patient preferences, focus discussion too narrowly, and actually ignore patients who are communication impaired. So in neurology, for me, it becomes important to pay attention to this. And if somebody says they made a living will, then you assume that whatever they made is good enough. So again, I'll show this to you. And I'm going to now switch to explaining to you what has changed. Some of you have heard that the Supreme Court has made this now possible. Now, the Supreme Court actually had made the Advanced Medical Directive valid in 2018, right? But what they did at that time was they made a requirement for the appropriate authority to be the judicial magistrate first class. Across the world, ideally, it's only done before 1 or 2 witnesses. Not in every place do they even require a notary, but by putting in the requirement for a judicial magistrate first class, they practically made it impossible. Because wherever, and this is at least 4 places that I'm aware of, where the JMFC was asked for permission, they said, we have no orders, we don't know about this, we don't have the time, and so on. So effectively, for 5 years, maybe about 3 or 4 of these were, and they became publicly known. So in January this year, the Supreme Court finally revisited the original judgment and removed the requirement for this to be signed before the judicial magistrate first class and said a notary public is enough, right? So the requirement for witnesses stays. If you look at the document, the FAQs, then it suggests who can be witnesses, who cannot be witnesses, and so on. So the person who's making it has to sign it, and it has to be signed before 2 witnesses and a notary public, and that is it. Nothing more needs to be done. You need to make sure that it is available with the family, and especially it's available with whoever is going to make these decisions. But I'm going to actually uh, take it a little further and speak to you about how we hope to make this possible. Does everybody recognize this picture? Hema Malini, Sita or Geeta. Giving a lecture, Babu. Giving a lecture. Yeah. Yeah. So, now, why do I show this picture? Well, the thing is that palliative care and advanced care planning actually evolved. They're twins. They both look after the same interests of the same individual patient. Palliative care originated in the United Kingdom. It works best when you have universal health care, which means palliative care is actually paid for by government and is available to everybody. And originally it began with oncology. Remember when I showed you the trajectory of cancer, you know that after a certain point, the patient, the doctors, nobody makes decisions. It's cancer. It's the cancer that makes ethical decisions and so on. So in some ways, for traditional palliative care, and oncology patients obviously have a lot of pain, a lot of palliative needs. So it became simple that palliative care necessarily would be focused on oncology. Look at the United States, private healthcare, driven by profit, insurance, and so on. And there it became more of an imperative to develop advanced care planning. And you can see the importance of advanced care planning is substantially higher when it is non-oncology. Now, as palliative care moves out of oncology and into non-oncology across the world, it becomes more and more important for advanced care planning to come into its brief. Typically, the organizations that set up and run advanced care planning in the United States, in Australia, in Singapore, have nothing directly to do with palliative care. But we in India believe that palliative care needs to own advanced care planning, and the IAPC plans to take on the responsibility of setting up and running advanced care planning for India, hopefully over the next few months. And I hope we have Dr. Savita Butola also here. I'm going to stop at this point. The summary, I guess you will understand from this what we've spoken about. In the PDFs that you will get, all these resources are listed, as also some free materials that I strongly recommend that you look at and read. If anybody wants anything more, you're welcome to reach out to me. This is my email ID. You can connect with me on WhatsApp also, and I'm more than happy to help. I'm going to mute for a minute while I take a call, and then we'll come back with questions. Thank you.
Thank you, Roop. Do you want to stop sharing screen and then?
I'm doing that. Yep, there it goes. I'm going to mute for a minute also.
All right. So in the meanwhile, can I request our participants, if you can, to turn your cameras on, if your bandwidth allows it. We'll just go into a small, discussion section now. We've had a lot of information brought to us by Dr. Gursahani. So if anybody has any questions or any comments, then now's a good time to also just make a note of it in the chat box, and then we'll take each question one at a time when Roop comes back online. If there are any questions that I can answer, I will try and do that while we wait for Roop. And Dr. Savita Butola is here, Secretary of the Indian Association for Palliative Care. And thank you, Savita. Yeah, Ravikant, please go ahead. Do you want to wait till Roop comes back, or you can go ahead? Oh, okay. Would anyone perhaps like to share any experiences while we wait? Here's Roop. Roop, you're back. Ravikant had his hand up. So Ravikant, can we hear from you, please?
No, my question is that, see, these aspects, whatever is very much practical and also quite relevant in the current day scenario. But problem is that when it comes to cities like type 2, I mean tier 3 towns or cities, where there is no education at all, and giving proper awareness and education regarding these aspects, that is the first step. See, let us say I am in a city which is quite modest, but thing is, practically speaking, there is not even few individuals who has access to any of this, even people from upper crust of the society. It's a practical challenge. And the other aspect is that even if people are willing, there is no place where they can approach, because when if they go to an attorney who has to do the needful, that is bit costly even for a people like, but there's no education and awareness regarding these aspects. So whom to approach and who can do the needful? Just I need some comments on this. Thank you.
Is Savita there? Is she?
Savita is unable to talk.
Okay, fine. Okay. So let's look at it this way. Obviously, we are at the beginning of this process. It's barely been 2 months, right? So IAPC will set up a whole process. I mean, Pallium, all of us will be part of this, where we will make sure that everybody has materials. And we do not want this to be a complicated kind of a thing there. Although I've given you all the details in this, you will realize that these are conversations that you have at home with your family. I mean, it's really going to be something that flows easily, except that ideally it ends with a document, right? So it's not going to be a complicated thing of people requiring much education. And you will find that you don't really require too much education to understand. It's generally, there are people who've been through this issue, and in the sense that they've seen a loved one or somebody else pass away in the ICU, and they know what they would want and they wouldn't want. You can start with that. And then obviously we go further until it's going to be like a rolling ball. We expect it to gather momentum as time passes. In the beginning, obviously it will be more difficult.
Thank you. Thank you, sir.
I'll highlight also the fact that while we wait for these procedures to fall into place, or for this kind of awareness to be integrated more into, a healthcare provider's, like what Roop was talking about, at some point it should be part of the system. But while that happens, let's also not forget how powerful this particular process is in initiating the conversation and clarifying wishes at home. And the conversation is quite key, because before we even get to a document that someone churns out, we should be able to have this conversation amongst people we care about. So I think one of the most powerful aspects of this document is it gives us guidance on how to have this conversation.
So if you look at when you get the PDFs and you look at the script, start using these sentences, and you will find they will flow. The more you use them, the more easily they will flow. Who do you want? Who do you think you would like to make decisions? Now that is a question that can be asked to people who are in dementia at a stage where they literally require help to go to the bathroom, and yet you ask them, who will make these decisions for you? They say, they point. So you get these things done. It's for us to start using them in our practice. Don't look on. I mean, I've shown you the ideal, but bits and parts of this should come out into our practice.
Definitely.
Savita
Thank
is
you.
and can participate in the conversation now. Savita, Roop, you wanted to address that.
Savita, I've already said that the IAPC is going to lead this effort. And I have also made the point that we should look on it the same way that pediatricians look on vaccination. It's an essential part of their job now. Earlier, pediatricians would not do vaccination. But I think in the same way, this is like a vaccination for the mind, which palliative care has to take on. Savita?
Thank you, Dr. Roop. And thank you, Pallium, for allowing me to join today. I'm joining as a guest person. Thank you so much. But I wanted very much to be part of this, to listen into what Dr. Gursahani has to tell about the latest changes in the guidelines. And let me assure you that IAPC is happy to work with all the stakeholders, and especially Pallium and other members who are willing to take this work forward. We are already working on it. The CC has approved. So we are going to, first of all, do a massive advocacy and awareness drive, especially talking to the people who are involved, the stakeholders, the patients, the relatives. And then we are going to take it forward as best as we can. So thank you very much. And in case you need any guidance, Smriti has already given you the links for the documents. So whenever we want to go to a lawyer or somebody, even a doctor, we need to take these things along because people don't know about it yet. So thank you very much.
So if I can just pose a question to the two of you, would you say that one of the barriers has been the attitude of the medical fraternity, who is unclear on where they stand legally in such issues?
Oh, okay. So, of course, this session was about advanced care planning, so I didn't delve too much into the the decisions that have already just come out in this past judgment, in this recent judgment. So, in the recent judgment, there were two parts to it. One part was that they made making the advanced medical directive much simpler by using a notary. The other one was what happens when somebody has to withhold or withdraw care. Withholding is still relatively simple. It's withdrawing that becomes an issue. So if you will see, even this document, it says that it has to be confirmed by a panel of 3 doctors, which is where it comes from. The Supreme Court said that no doctor can make this decision alone. It has to be at least 3 doctors who should sign off on this withdrawal of care. And in institutions, now this also is something that has to be set up. Institutions should have a mechanism which is called the second committee of checking these decisions and confirming them within 48 hours. So basically, this mechanism will be done within the hospital itself. Earlier, you had to go to the JMFC, the district collector, and so on. All of that is gone. It is a process that can be completed in the hospital, except that it cannot be unilateral. One person cannot sign out. It has to be done by 3 doctors at the first stage and then ratified by a different team of 3 doctors. Now, while all these blocks fall into place, remember that one thing that is very clear is that obviously while your institution puts all of this together, if you have to make these decisions, if you document, if you make sure that you're transparent, if you make sure that you're not acting unilaterally, you're protected. That's all that I can tell you very, very, very clearly.
No, that's very useful. Also, Roop and Savita, there are lay people amongst the in the audience.
Oh.
So just to also backtrack a little bit for the benefit of those. The reason why the conversation is so important before you arrive at the document is to know the wishes of the person that you're caring for. That's one. 2, I just want to highlight one thing: the withholding versus withdrawal of life support. they amount to the same thing, which is no futile interventions and allowing for, the natural trajectory of the illness or natural death or whatever. But there's a psychological difference in the way we perceive it also, because if it's harder, like Roop just said, it's harder to withdraw, and that has been recognized now in this latest judgment. So the conversation also allows you to hopefully allows you to avoid being in that position where you've gone so far past the line that you now have to come back, and that's where the hassle is. So Roop, you want to say anything about that?
Yeah, so withholding and withdrawing are medically, are ethically considered equal. Because if you look at withdrawal, it is basically withholding from that point on. So you cross the line or you withhold after that line. But either way, it effectively becomes the same thing ethically. But psychologically, it is never equal. And in our legal system also, although in other countries it's been taken as equal, in our legal system also it's not being taken as equal. So withholding is something that is what the advanced care plan actually should be doing. That somebody should not get a CPR. Somebody should not be intubated. Somebody should, towards the end of life, not get Rice tube poked into them. Right? So that's the power of the advanced care plan, that these decisions are made before you get to that point. Of course, if you cross that point, then this plan obviously steps in. And it's important to understand that all of these are documents that are, you have forms and documents available for doing all of this. They are available in the AIMS guidelines. They are available in the Blue Maple document from KMC Manipal. We all need to start getting used to using them.
And one last thing, I'll just sort of, because I know this is a question that must be there, the use of the phrase passive euthanasia. Can you please clarify that, please?
Oh God. Yeah, so, right. So we really don't like the term passive euthanasia, though it tends to be used again and again in the medical and the legal system. So let me clarify that by using some examples. Now, the first, and these are a few stories that I usually tell. One is the story of this friend of mine who had a Labrador who was getting older and older, and by the time he was 15 or 16, he was really arthritic and in pain. But the family loved him, the dog loved them, and it was very difficult for the family to let go. But eventually they decided and they gave him an injection and he went to sleep. That is euthanasia. Euthanasia is for animals. Sentient human beings take charge. So how do people take charge? So let me give you another example. This was a friend of mine who was working this was the stories from a friend of mine who was working as a registrar in a UK hospital. And he was in the ICU when a patient arrested. Arrested meaning heart stopped. So he was shocked. The patient got shocks, and with that, the heart restarted. And this happened 2-3 times until finally the senior doctor came in and started some medications, and things settled down. The patient became fully conscious. And the patient asked for the doctor on duty, which was my friend. So my friend went to the bedside and the patient held out his hand. And my friend thought that he was going to thank him. No, the patient held his hand firmly and said, "Don't do that to me again." So, and well, because this was the UK, everything started to fall into place. Palliative care came in and the patient was moved out and passed away a few days later. Now that is what we just spoke about. Withholding or withholding, right? That is what in India is called passive euthanasia. So that's not really, it's an active decision by the patient. And then of course you have active euthanasia where people may be given medicine to let them pass away. And that is not something that is going to happen in India for a long time. It's possible in some advanced economies because they have the social mechanisms to police it. We are far from that. So don't even think about it. Why did this term euthanasia come up? The term euthanasia actually came up in Germany between the First and the Second World War, they decided that some people, and it actually began with neurology and psychiatry patients, some people did not deserve to live. Their lives were of no value. Eventually, the slippery slope took them to Jews and so on. But when the gas chambers began, the euthanasia was for neurology and psychiatry patients. Almost 3 lakh patients died in the gas chambers. Remember, so that is euthanasia, which is why, because euthanasia has such a terrible history, we just don't like the term. And we don't like a term which goes all the way from patient autonomy to murder. How can you have one term that covers everything? Sorry, a little long-winded, but I hope.
No, absolutely perfect. Savita?
Yeah, I would just like to add a little bit. In palliative care, we say that if you give good symptom control to the patient, you give good pain management, give good psychological support, the patient is likely not to ask you for euthanasia. They will have no need to ask for euthanasia. And another thing is that all this process of witnessing and notarizing that we were talking about is not applicable for every patient. This is meant for hospitalized patients basically. And when we are in palliative care, we need to build up our prognostication skills also, so that you are very confident, you are very clear about what is the expected likelihood of that patient's survival. And when you are talking to your colleagues or when you are talking to the family, you yourself have to be clear about it. Only then you can convince them. And only then the patient is guided to make an informed decision. We believe too much, these days we rely too much on investigations, and we are losing out on our clinical and skills of prognostication that we need to go back to. That's what I wanted to say. Thank you.
Very well said. Senior, how much? We have about 6 minutes still.
Yeah. Anything in the chat box? I mean, that I can see something. No. Okay. Nothing. No. So I'm sorry. I think I didn't realize it was lay people on. This was a little, I think, heavy for. But anyway, I mean, if anybody of you wants to look at a very, very basic presentation, it's there on YouTube somewhere, I think, on advanced care planning. I think you people have put it up also earlier.
We have the Arohan one, but I think
Yeah.
it's a very eclectic group as well, Roop. So it's I think your information was pretty spot on. And plus, once we go through the PDFs, I'm sure that all the dots will be joined. Of course, please go to the Pallium. I've shared a few links from the Pallium India website. You go to the resources tab and you will find various resources under the Narcotic Drugs and Psychotropic Substances Act. There's one tab on end of life care. So you can find resources there, including the advanced directive document as well as the ICMR.
So can you, sorry Smriti to interrupt, but can you actually make a tab for advanced care planning in the end of life care?
For sure, we'll do that.
Yeah, because now there's going to be, now that we are actually going to be doing it, I think people will look out for it. So
definitely.
I think we should have that. And there are some that I have shared here. Maybe we can work on that and put up more there.
For sure, we can do that. And also Roop and Savita, you're already aware of this, but I would like to also bring this to the attention again of the FCPC participants. Some of you have expressed interest in this as well. We have already started a death literacy sort of series in Pallium India. We've done one on advanced care planning, and this is citizen-led. It's what people who have attended these various programs, etc. Yeah, so Roop, you should see the YouTube links to that. So we had one on advanced care planning. We had one on estate planning, which was extremely useful. I can vouch for it because we shot that webinar and then I needed exactly that information a week later. And it was very, very, very helpful. So for those of you who are interested in joining this, and become a part of it, 2 of you have reached out. We are working on the nuts and bolts of what it's going to look like, but get in touch with me and we will plug you into this campaign. And we really want to hear from people on the ground about what your experience has been. And because I think all of us present here, we know that, when we are representing in the corridors of policymakers, we really need to have our ears to the ground and get back from you what's happening, what your experiences have been. And to Ravikant's point that awareness is lacking and advocacy is needed, it's going to come from folks like you, really, who are going to educate your communities. So open invitation to come and join the movement and become that advocate. So thanks, Roop, and thank you, Savita, very much for joining us and for that, that boost of confidence and encouragement. I know that IIPC is going to lead the way on this, and we will be happy partners. And thank you, Roop. It's great to see you again.
Yeah.
Thank you. Thank you for letting me on board. I just came in to listen, actually.
Do it more often.
Thank you.
Sure. Bye.
Bye-bye.
Bye.
Thank you all for joining us today. I think we could wind up the session. Bye-bye.
Bye.